like FIPP, EDPMs and CIPS. Now pain from NMC, pain is also a part of undergraduate curriculum. During MBBS, core competencies under anesthesia include pain medicine as well. These are the core competencies of pain which are a part of anesthesia competencies. There are a total of 63 anesthesia competencies, out of which 7 are dedicated to pain. Then recently at MBBS level, electives have been introduced where students can choose 2 electives, each of 15 days duration. So each department offers electives to the patients. So Department of Anesthesia can offer pain medicine as an elective. In our hospital, we are offering pain medicine as an elective, acute pain services, chronic pain, and pain camps during that duration. Then pain education in postgraduate curriculum. As per NMC, the pain management services are mandatory for MD as well as DNB anesthesia courses. And all areas of pain management, including interventional pain procedures, are a part of MD and DNB anesthesia. Currently it is out-of-pocket expenditure for pain, but yes, some procedures are being included and the way forward is we look forward to make pain medicine as a public health measure and apply precision medicine in pain management, and also apply integrated approach to pain medicine as a national policy. Thank you so much.
Thank you, ma'am. To move forward, we are privileged to have Dr. Arun Agarwal sir, who had been ex-dean Maulana Abul Kalam Azad Medical College, New Delhi, where he had been faculty and retired as a dean from there. Subsequently, he had been associated to a number of medical institutions. For example, Delhi Medical Council of India, ABAS, and he had been instrumental in opening many medical colleges across India, also in Maldives. So we invite Dr. Arun Agarwal sir to kindly felicitate our chief guest today, Dr. S.N. Raja sir. Yeah.
बेटे पहले फ्लावर्स को
Yes.
Thank you, Dr. Pandey. Thank you for giving me this opportunity to be amongst you, your colleagues, and I am visiting your place after 15 years. It is absolutely undesirable, but circumstances, and more so, a opportunity to meet Dr. Srinivasa. Well, to introduce Dr. Srinivasa, to start with, Dr. Pandey, you both are graduate of Prince of Wales Medical College, Patna. Do you know which was the first medical college of India? Anybody? Quickly. Who said that? Who said that? Calcutta Medical College. Congratulations. Who said Madras? You are wrong, sir. Absolutely. 28th January 1835 was the first medical college. There was a competition. Who will come first? And Calcutta Medical College won the race to become the first medical school of India, followed by within 7 days मद्रास मेडिकल कॉलेज. आप दोनों ठीक हैं, लेकिन 7 दिन का अंतर पड़ गया. Followed by J.J. Medical College, followed by Undivided India King Edward Medical College, Lahore, followed by King George's. I am graduate of King George's. Followed by लेडी हार्डिंग से कौन है यहाँ पर? एनीबडी फ्रॉम लेडी हार्डिंग? ऐसा हो ही नहीं सकता कि क्राउड में लेडी हार्डिंग ग्रेजुएट ना हो. प्राशर, ये क्या हो रहा है तुम्हारे? हैं? Followed by Andhra Medical College in 1923, Visakhapatnam, followed by Prince of Wales in 1925. So, that sort of historical background is there with Prince of Wales Medical College, Patna. And needless to say that after that Dr. Srinivasa went to US, and there today he is in a position of professor of anesthesiology and neurology and director of pain research at Johns Hopkins. The Johns Hopkins is a place where every doctor will dream कि यार थोड़ा सा एसोसिएशन होता तो अच्छा होता. And he has achieved such a big height at Johns Hopkins. So we feel privileged that we. Of course, he did his residency in anesthesiology at University of Washington, Seattle, and postdoctoral training at University of Virginia in different places. He is member of Scientific Advisory Committee of World Congress, chair of Scientific Program, secretary of International Association, chair of Neuropathic Pain. I think it looks like अपने आप को बिल्कुल डुबो लिया. मैं एक क्वेश्चन पूछूंगा आपसे, पेन मैनेजमेंट में दर्द दिल भी होता है क्या? दर्द दिल, दर्द जिगर, बड़ा ये डिफरेंट टॉपिक है. क्यों पांडे साहब? दर्द दिल और दर्द जिगर डिफरेंट टॉपिक. Of course, presently he is chair of educational program of working group to help coordinate. He had been editor of Journal of Anesthesiology, member of editorial board of pain, section editor, educating pain practitioner in developing nation. That is very important. अभी हम बात कर रहे थे, पराशर मेरे दोस्त हैं ENT के, पेन मैनेजमेंट इंडिया में आ चुका है, लेकिन बहुत अर्ली स्टेज में. 140 करोड़. अभी हम लोग केवल पेन मैनेजमेंट की बात करते हैं ना, बड़े बड़े शहरों में करते हैं. डॉक्टर पांडे अभी छोटे शहर में तो नहीं गया ना पेन मैनेजमेंट. इट्स अ बिग नीड. एंड ऑफ कोर्स, needless to say, he had been member of FDA, member of US Federal Pain Research. मैंने कहा ना डूबे हुए हैं डॉक्टर श्रीनिवास पेन में. He got approximately 250 publications and he has edited 5 books. He's privileged and he has been awarded so many prestigious awards. E. Fordyce Clinical Investigator Award, John J. Bonica Award, John J. Bonica Distinguished Lecturer Award, and recently he has been awarded J. Edmund Sheraton Plenary Lecture and recognition as a Fellow of American Society of Regional Anesthesia. क्या चाहिए हमको? एक हमारा इंडियन कोलीग जो प्रिंस ऑफ वेल्स मेडिकल कॉलेज से स्टडी करके he decided to go abroad, and needless to say जो आपने अचीव किया है डॉक्टर श्रीनिवास, it is out of your dedication, pure and pure dedication. And this campus of Asian Hospital, Dr. Pandey, thank you for bringing Dr. Srinivas, and I'm sure his deliberation will be very useful, not only to this campus, through each one of us, to each and every part of it. Please.
Good morning, ladies and gentlemen, and thank you, Dr. Agarwal, for the generous introduction. It's my real pleasure to talk to you all this morning, and my special thanks to my classmate and long-term friend. Between us, I think we have a partnership of more than a century, and we all still run out. I'm not out as yet. So, my special thanks to Dr. Ajit Thakur as well for arranging this. What I hope to do in the next half an hour is to provide a broad overview, because I know this is a mixed audience of multiple specialties, of pain and its management, and provide you with the perspective of some of the challenges even experts in pain management are facing today. But these challenges are also opportunities for us to go ahead. And I'll end with a bit of hope that there is hope for the future. Okay. So let me start with kind of defining pain, and my friend Dr. Jyotsna already did that the original definition of pain by the International Association for the Study of Pain was almost 40 years ago, and they defined pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. But about 4 or 5 years ago, the president of the IASP wanted to revisit whether we need to change this definition, which is almost 40 years ago. And I was fortunate to be asked to chair a committee of international experts, about 14 of us together, to discuss whether this definition needs to be changed. And we talked about it at multiple meetings over a period of 18 months just to talk about a single definition. And we'll come to why this might be important. And this was a publication we did about 3 years ago. And we redefined pain as an unpleasant sensory and emotional experience associated with, or resembling that associated with, actual or potential tissue damage. So it looks like, we didn't make too much of a difference from the original definition, and yet we spent 18 months doing this, and you can say, why did you do this? And Forbes magazine said after 40 years, pain definition has been updated with aiming to include those who were left out. So what did we change? The main thing with the original definition was, it said, described in terms of such damage. So what that means that it excluded certain populations. Infants who couldn't describe their pain were excluded. So similarly, the elderly who may have had some communication issues, it doesn't mean they don't have pain. They still experience pain. So to be able to include all populations, we had to take the word described in terms of such damage and make it as resembling that associated with. So one of the things we had to do was, and what are the concepts that we said? We wanted the definition of pain to include both acute and chronic pain and should apply to all pain conditions, nociceptive, neuropathic, nociplastic. It should be applicable not only to humans but also non-human animals, because the International Association for the Study of Pain was not only treating patients or involved with clinicians, but also was a research organization which was using animal models of pain as well. So how do we describe pain in animals? And we also did this, not only did we have a single one-line definition, but we focused on some accompanying notes to emphasize some of the complexity of the pain experience. So we had 6 bullet points along with that, along with the one-line definition, and these were, first, that pain is a personal experience, and it's influenced to varying degrees by biological, psychological, and social factors. So pain is not just a sensory experience, but it's a sensory and emotional experience, but it's influenced by biological, psychological, and social factors. And that pain and nociception are different, so it's not just injury to tissues, and therefore cannot be inferred solely by looking at the activity of sensory neurons. So it is a conscious sensation, and therefore it's more complicated than just activity along sensory nerve fibers. And thirdly, that through their life experiences, individuals learn the concept of pain. The additional notes that we added was, a person's report on the experience as pain should be respected. Often, as physicians, we think patients are exaggerating the pain, but what they experience, what they tell you, is something that we need to respect. And although pain serves an adaptive role, and we'll talk about this in a minute, it may have adverse effects on function and social and psychological well-being. So it's not just a symptom that we need to treat, but we also have to look at the social and psychological aspects of pain. And that verbal description is only one of several behaviors to express pain, and therefore inability to communicate does not negate the possibility that a human, such as an infant, or a non-human animal experiences pain. So, we don't need a patient to tell you verbally that they have pain. We should be looking at experiencing pain. So, but not all pain is bad. Acute pain is a protective early warning sign, and sign of a potential injury from a heat, a cold, or intense mechanical stimulus. And as we all know, most of you physicians here, that pain is the most common symptom that brings the patient to the physician, and therefore protects the organism from injury or warns the individual of an injury. And here is a good example why pain condition or a symptom or a disease. So, family of patients that were first discovered in Pakistan, where a single sodium channel was mutated. And this channel was NAV 1.7. And this loss or mutation of this channel resulted in a loss of the sensation of pain, a disease known as congenital insensitivity. hot, burning extremity. And in these patients will not survive in this country where the temperatures are in the hundreds. And in fact, even in in the U.S., we would see these patients coming in with either ice packs in their legs because cold was the only thing that relieved their pain. So any warm sensation would increase their burning pain sensations. So here we see the importance of pain. Even changes in a single gene, a mutation of a single sodium channel can result in two different disease conditions. So let's talk about the different types of pain. One is the nociceptive pain, which often results from tissue injury or disease. Typical examples of this are postoperative pain, mechanical low back pain, arthritis, or sports injuries. The other more chronic type of pain is neuropathic pain, which can result from persistent pain after shingles or postoperative neuralgia, neuropathic low back pain with radiculopathies, polyneuropathies such as diabetic and HIV, or things like trigeminal neuralgia. And in cancer, both these pain states, nociceptive and neuropathic, can coexist, and it could be a mixed type of pain state. More recently, there's been a description of a condition called a type of pain called a nociplastic pain, typically exemplified by irritable bowel syndromes or interstitial cystitis, etc., or fibromyalgia. So, I know my friend Narendra can. So when we studied about pain, what we learned was the afferent pain signaling pathway. The receptors in the periphery, the C fibers that conducted the pain signals and transmitted them to the spinal cord in higher centers, and that was in the cortex. But the most important change in our understanding of pain has been not on the afferent pathway, but much more importantly, the efferent pathway, the modulation of pain that occurs at multiple levels along the pain pathway, from the cortex to the midbrain, as well as the spinal cord and the periphery. So we'll talk a little bit later why this understanding of these modulatory mechanisms is extremely important in our understanding of the pain signaling process. And so when we think of this pain modulation, we can think of this as a volume control mechanism, that there are excitatory mediators that can increase the volume on this pain signal, as well as inhibitory mediators that can decrease the volume. So the excitatory mediators can be things like bradykinin, histamine, serotonin, while the inhibitory mediators could be monoamines such as decade or so, is that this concept has changed to a more team-based concept, where the patient is the center of the team. Maybe the surgeon is still orchestrating this team, but the team consists of a physician who does a preoperative evaluation and preparation of this patient, a perioperative pain team, and the anesthesiologist who looks at the intraoperative aspect, by a perioperative pain physician or a team that manages the pain in the perioperative period, but includes others such as occupational therapists, physiotherapists, dietitians, and nurses, so that the patient can be taken care of from a multitude of aspects. And one can ask, has this been beneficial, and how do we do this? So the goal of this ERAS, or is to reduce this inflammatory response and the stress response associated with surgery, accelerate the recovery and reduction of hospital stay. And this has to be multidisciplinary because one needs to optimize the perioperative nutrition, early mobilization of the patient as well as the oral intakes, educate and motivate the patient to participate in these, and standardize the perioperative anesthetic plans so that you minimize some of the opioid usage and the associated constipations and effects on bowel motility. And typically it involves a multimodal analgesia. And clearly meta-analysis have shown that implementation of this results in decrease in the length of hospital stay, a decrease in complications such as urinary tract infections, respiratory complications, as well as cardiovascular complications. And I have a pediatric intensivist who's focused on this early rehabilitation in pediatric patients, and thanks to her, she shared this slide with me. Here are a couple of patients. The one in the left is after a thoracic surgery. Within 2 days, she's out walking with the help of a team. The second is a patient, a child on an ECMO. This is extracorporeal oxygenation, and still on a bicycle with a team of nurses assisting this patient. And the third is a 2-year-old, 2 days after her open heart surgery, who's obviously scared to be asked to walk. But if you give her something else, give her a little car that she's driving, she's able to, mobilize herself. So this involves a team, a lot of individuals, but this has made a significant difference in how we treat and manage patients, including pediatric patients. But what does it take for you all to be able to do something like this is that the challenge is going to be formulate a program that works for you, but determine how well it works in your institution. And this requires a periodic, honest evaluations of the outcomes. So in a recent trip that I made to Turkey, I was impressed by this shopkeeper who was very honest about it in saying that his product was a genuine fake watch. Okay. So let's move from an acute pain state to a chronic pain state. So chronic pain, unlike acute pain, is the maladaptive nervous system. So it's not a symptom, but often it could be a disease by itself. And let's take neuropathic pain, which is one of the most common chronic pain state. And it's defined as a pain caused by a lesion or disease of the somatosensory nervous system. And as mentioned by Dr. Josna, that it is fairly common across globally. It's about 7 to 10% of the population have some chronic neuropathic pain. And the risk factors are old age, women, genetic background, as well as cognitive well-being. And there's a significant burden of disease associated with it. That is, the impairment of sleep, quality of mood, depression and anxiety are common. And depending on the disease state, for example, patients with stroke, about 10% of them have persistent chronic neuropathic pain states, while spinal cord injury patients and HIV neuropathy patients may have as high as 60% of these patients may have chronic neuropathic pain. So depending on the disease etiology, the incidence of neuropathic pain may vary. And these conditions such as focal neurological lesions or polyneuropathies affecting the peripheral nervous system, or it could be from central nervous system such as spinal cord injuries, strokes, syringomyelia, etc. So both peripheral nervous system as well as central nervous system disease states can be associated with chronic neuropathic pain. And we've spent a lot of time in trying to understand the mechanisms of this neuropathic pain states. In a lot of states, the ectopic activity in the peripheral nervous system is the spark that initiates this neuropathic pain. So normally pain is the activity in nociceptors or pain fibers initiated by a noxious stimulus. But in neuropathic pain states, there's often ongoing ectopic activity in these nerve fibers. And you can think of this as a spark, which in turn initiates a wildfire by creating neurochemical changes, structural changes, and functional changes in the central nervous system, a phenomenon which is called central sensitization. And therefore, as we talked about earlier, understanding what normally modulates the nervous system has resulted in the development of treatments to alter or enhance these modulatory mechanisms. So drugs such as tricyclic antidepressants or gabapentin or tramadol work by enhancing the endogenous pain modulatory mechanisms working on amine or opioid mechanisms. We also know that things like psychotherapy, complementary therapies, or neurostimulation or neuromodulation mechanisms have also evolved from our understanding of how the pain pathways, the pain signaling process can be modulated. So let's look at the available drugs, and we've done periodic evaluations using meta-analysis. And in 2010, one of the first studies that was published, we looked at a number called NNT, which is the number needed to treat, which is how many patients do we have to treat to get one patient who gets 50% or better response. So the NNTs for most of the drugs for neuropathic pain, and this is called a bubble plot, the size of the bubbles are the number of patients who have been studied in different clinical trials. Was about 4 to 6, so let's say NNT of 5. And the same process was repeated 5 years ago, a paper that we published in Lancet Neurology. This has even shifted to the right, which means even though we studied more patients, these drugs seem to be less effective across the population. What does this mean? Let's take an example. Let's be very optimistic and take an NNT of 5. What that means in real life is that if you treat 5 patients, there's only one of those 5 patients who's going to be satisfied and will get better than 50% relief from their pain. So this is the challenge. Even at the present stage, most of the drugs we have are inadequate, either because of inefficacy or because of the adverse effects such as CNS side effects, sedation, dizziness, etc., associated with these drugs. So here is the opportunity. Let me just give you what the last recommendation was. We just met in Paris about a month ago. We are updating this guidelines, and hopefully at the end of this year there'll be a revised guidelines. But the old guidelines said for neuropathic pain, the first line drugs were pregabalin, gabapentin, or extended release gabapentins, tricyclic antidepressants, and the other class of antidepressants called the SNRIs. So these were the first line drugs. The second line drugs was a combination of drugs, including tramadol, lidocaine patch, capsaicin patches, and a very weak recommendation for third line drugs. So as you can see, there are few first line drugs available for our patients. So Sir William Osler was a chief of internal medicine at Johns Hopkins for several years. And he said that variability is the law of life, and as no two faces are the same, so no two bodies are alike, and no two individuals react alike and behave alike under the abnormal conditions we know as disease. What that implies is the same medication may not apply or be effective in all patients. Each person is an individual, and therefore we have to treat them as individuals. And therefore, this is where the art of medicine comes in. So I've talked to you about some of the challenges in terms of the lack of adequacy of drugs. So as a clinician, we think of that as unmet needs, and we sometimes think of it as an uphill battle in treating these patients. But the scientists amongst us may think of these as opportunities. Let me give you a couple of examples of that. So in recent years, this CGRP, or calcitonin gene-related peptide, has been discovered to be a key molecule that could be related to migraine attacks. And this has led to a whole new class of agents, the anti-migraine, monoclonal antibodies that have been used for the prevention or treatment of medicine. So here is where the science has helped develop a targeted treatment for a chronic disease, particularly NAV 1.7, 1.8, and so recently certain pharmaceutical companies have developed a NAV 1.8 blocker, so it's specific to a single channel, and studies have shown now, it's been published, that it is effective in an acute pain model. They're now examining it in more chronic pain studies. So hopefully, we'll have a new class of agent based again on, research examining selective channels. And another area where, these significant advances have been made is in neuromodulation. A number of stimulation paradigms, such as cortical stimulation, deep brain stimulation, spinal cord stimulation, dorsal root ganglion stimulation, and even intrathecal drug deliveries have developed as a result of some of the enhances in our understanding of the physiology and the pathophysiology of the disease states. Finally, just to touch up on a significant need, which is palliative care, pain relief at the end of life. So palliative care is an approach that improves the quality of the life of the patients and their families facing problems associated with life-threatening illness. Initially, we would think of this as only something for cancer, but this could be any terminal illness. And the goal here is to prevent and relieve suffering through the early identification, correct assessment, and treatment of pain, other problems associated with it, including physical, psychosocial, as well as spiritual aspects. So in the past, when we treated patients with cancer, it was sequential. Initially treat the cancer, so anti-cancer treatment was the first stage, and then cancer pain, its relief, was closer to death. But the WHO has suggested that this model should be changed, and in developed countries, anti-cancer treatment starts, and the cancer pain management and palliative care also goes along in parallel with it. And in fact, they even suggest in the developing nations where maybe resources for anti-cancer treatment may be not as well developed, that the palliative care should be the more prominent aspects, even in the early stages of the cancer. So we need to think about aspects of treating patients with cancer from the very beginning that include palliative care as part of that. And the great Albert Schweitzer said that pain is more terrible lot of mankind than even death itself, and that if we can save our patients from days of torture, that's when we as physicians feel great and privileged. So to summarize, the challenges for pain physicians or physicians in general is that pain is a common problem, but the available therapies are limited by efficacy and by adverse effects. But that presents us opportunities. We've advanced in basic research, both in the physiology as well as the pharmacology and the pathophysiology, and translated to this understanding to new and safer targeted therapies. The hope is that the numerous novel targets will be identified in preclinical studies, such examples being the CGRP antagonists and the selective sodium channel blockers, and a whole host of G protein coupled receptors are being studied now. And the future of pain management is a personalized medicine, which is a change in paradigm, which stratifying patients into different subgroups and approaching drug management as well as other aspects of management depending on the needs of that particular patients. And this could involve a number of things, including stem cells, monoclonal antibodies, and even gene-based therapies. Thank you for your kind attention. And I'm told there may be some time for questions. And as the Albert Schweitzer said, there are no stupid questions, just an intelligent person seeking some information. I'll be glad to answer any of your questions if you do. Thank you. Thank you.
Thank you, sir, for a wonderful talk. It's not easy to address a mixed audience, and within half an hour, you did a perfect job trying to introduce the concept of pain medicine from acute till chronic and the various types, nociceptive, neuropathic, and nociplastic, and how pain management is important in ERAS protocol. So my question to you is, you introduced the concept of transitional pain medicine. So in Western countries, in your country, for example, are you having separate transitional pain services, or is it being dealt by the acute pain physicians as well as the chronic pain physicians?
Can you define what you mean by transition pain service?
I'm looking for an answer from you, because in our country it's not just being discussed. I've heard in a couple of Western conferences that it's being discussed in detail. So I want to enlighten myself about the concept of transitional pain services.
So what I'll do is to give you an idea of what we do in our group. So we have a separate team which call themselves as perioperative pain physicians. So while majority of their work is during the immediate postoperative period, but they're often the surgeons who think the patients had past pain problems, such as, say, chronic low back pain in a patient going for abdominal surgery. So these patients will come and be seen by this team even before they come for surgery, so they can plan what they need to do in managing their drugs or other aspects. But then they will continue, and then we have a whole separate of chronic pain physicians who are trained in managing these chronic pain patients. So often the communication goes from this perioperative team to this then the chronic pain team that then continues to follow these patients. So I agree that, we don't have a separate transition team, but the two teams talk together. So the perioperative team then continues and communicates with the chronic pain service, and we take over from there. Okay. But what you say is important in the sense that one of the most difficult or challenges is that the more recent studies have shown that an average of 10 to 12% of patients undergoing surgery do have persistent pain states. So the need to start treating these patients acutely and try to determine who is at risk to develop a chronic pain state and focus on those 10 to 12% to minimize the transition from acute to a chronic pain state. Thank you.
Good morning, sir. I'd like to know about your experience of cannabinoids in US. So we've recently got approval for treating it in epilepsy, like the epilepsy syndromes like West and LGS. But is it on-label or off-label for use of pain? So like for multiple sclerosis or chronic pain. So what is your experience using cannabinoids?
Okay. So this is a controversial topic, and you will have a full evaluation, what we call as the grade recommendation, hopefully coming up before the end of the year from this panel group of experts who are looking at this. But the bottom line is cannabinoids are approved for recreational use. So if there is an easy access in many states in the U.S. of cannabinoids. However, and as you said, there are some specific cannabinoids approved for epilepsy. But if you look at studies for chronic pain, the efficacy of cannabinoids is equivocal. The only condition where there seems to be some significant benefit is multiple sclerosis and myogenic pain states. But for neuropathic pain states, the data on efficacy is not that good. It's what we would call as, at this stage, inconclusive evidence for efficacy. Yes, sir.
Thank you, Prof. Raja. Nice presentation on the pain, and this has enlightened us. I'm an orthopedic surgeon. I'm Dr. Chaudhary. I came across chronic joint pains, back pains, and shoulder pains. And many of the patients, they are not fit for my job, means surgery, or they don't want surgery. And they have taken these paracetamols and tramadols and these for so long. They don't want medicines as well. So I have a little bit experience that if you give them nerve block, that gives them some relief. And if that block is working fine for a few weeks, then we advise them nerve ablation. So that was the practice in United Kingdom. For nerve ablation, we were sending the patients to the pain guys. So I had no follow-up after that. So I wanted a little bit your experience as to how good and how long they are for the patients, the nerve ablations. Thank you very much.
Thank you, Dr. Chaudhary. That's a question very close to our heart, and I'll tell you why it's close to my heart. And then I'll give you the answer for that. So the NIH has been, which is the National Institute of Health, the funding agency for all research in the US, has been very interested in alternative or non-opioid treatments for chronic pain states because we have a real problem of an opioid epidemic in our country. So they funded us a 5-year study that it's on its 4th year now. And we're looking at knee osteoarthritis, going from a comparison of some non-interventional therapies, including duloxetine as a medication, a psychological treatment, cognitive behavioral therapy, a combination, etc. And then they failed that to interventions, which including intra-articular injections and the nerve block and neuroablation. And we've just studied, this is a blinded study at this stage. We've studied 650 patients, and the goal is to finish by the end of August this year. So hopefully I can give you an evidence-based answer next year. So what I'm saying now is not totally evidence-based, but in general, our pain clinicians have also used a genicular nerve blocks to block the patients. Often that is a transient pain relief, and then if there is 50% or better relief, then they go to do a ablation. Radio frequency ablation is a common. Cooled ablation is also there. The data are a little bit mixed now from smaller studies. Some studies have shown that there may be benefits for up to 6 months, while there are negative studies as well. So it's a bit mixed right now in terms of data. But what our pain clinicians who are working on this particular study are saying that you have to choose more than just the 3 main nerves going to the joint, that you may have to ablate up to 9 of the nerves that, especially for the knee nerves going to that joint. So I think the technical aspects of this may have to be defined as to get a more longer lasting relief. Thank you.
Thank you very much.
Hi, that was just a wonderful talk. Ideally, what you want is somebody who is in chronic pain management team to be a neurologist as well as a combination of anesthesiologist, which you are. So it's just absolutely great to hear you. Now, we talk a lot about afferent pathway of treatment, and I think it's mainly focused on that. But you also spoke about efferent pathway, and I think more work obviously is going on, but things like deep brain stimulation, thalamic pain syndrome, etc. So I think it does make a difference, deep brain stimulation in parents or sometimes even children, pediatricians, we would get involved with those who have got significant, pain. Thalamic stimulation, or deep brain stimulation was really helpful. What's your experience, please? Thank you.
Can I just ask, what is your specialty?
Well, I'm a pediatric neurologist, and I've worked in UK for about 25 years.
It's true that one of the aspects that Dr. Josna just emphasized is a pain physician needs to be more than just a pure pharmacologist or a pure interventionalist, has to have a broader understanding of how to evaluate a patient for pain, which includes neurology, obviously. In some cases requires a musculoskeletal examination, like orthopedic surgeon or a rehab medicine physician may do, as well as understanding of the neuroscience aspect of it. Neuromodulation has become, I spent half a slide on that, but people are spending careers developing neuromodulation techniques and therapies. The deep brain stimulation, unfortunately, has not been so far as effective in larger trials. And maybe the critical aspect is where in the deep brain you stimulate may be the important aspect. However, interestingly enough, for at least many peripheral neuropathic pain states, selective dorsal root ganglion stimulation or spinal cord stimulation has been, at least been shown to be more effective. The one area that seems to have some good clinical evidence is transcranial magnetic stimulation, cortical stimulations, especially in M1 areas. So there are some areas of the brain that could be stimulated to achieve good analgesia in chronic pain states, but more research needs to be done in that, definitely. Yeah. Thank you.
Before concluding the session, I may have the privilege to ask a last question. In intensive care area, we do have post-operative patients and sometimes elderly patients having pain. We don't know because ICU patients are usually having many comorbidities, and sometimes we need to wean off them from the ventilator despite there may be some pain or something. So do we have some ray of hope from the other end of the tunnel, an agent which can, besides non-steroidal, which is nephrotoxic in case of multiple comorbidities, do we have some agent or something developing like which causes analgesia and there is no fear of patient getting sedation or maybe easily weaned off of the ventilator or something like that?
I wish I had that magic bullet here. No, I don't. But I think there are some studies and some individuals who've been looking at a drug called ketamine, which is obviously an anesthetic, but it also has, it's a good analgesic, but it also has an effect called an NMDA antagonist, so N-methyl D-aspartate antagonist. So, and N-methyl D-aspartate mechanisms seem to be involved in this process of central sensitization. So, low-dose ketamine infusions have been tried at least in part during this extubation process. How successful it is, I'm not 100% sure as yet.
Okay, thank you, Dr. Raja. Such a wonderful, mesmerizing lecture, and thank you all the guests, audiences for wonderful interactions. Yeah. So, Thank you, sir, for taking out the time to be over here. Now, may I request our CMD, sir, Dr. N.K. Pandey, sir, to please facilitate our guests and other speaker, Dr. Jaiswal Agrawal, sorry, Jyotsna Agrawal.
It is great privilege to welcome you here, sir. Popularly known as A.K. Agarwal, he has been a great educationalist. Forget about him being dean. I was associated with the National Board of Examination for 3 years, and he was the guiding force in modifying many of the courses and creating many new courses. So I'm extremely thankful to you, sir. I'm honored by your visit here today, and I would like to thank you on behalf of Asian family for your early morning visit. Thank you, sir. Thank you so much.
Dr. Jyotsna Agrawal. Dr. Jyotsna Agrawal, please. So, yeah, some word of wisdom from our CMD, sir, to conclude the
There are
session.
no words of wisdom. I'm being a surgeon myself. I'm looking for one substance that will relieve pain without affecting the function. And the person who gets it will be candidate to visit Sweden. I can tell you that. So I'm looking for something like that, and hopefully when we have people who have dedicated their life on pain, they will find something like this. You are still in the queue, Raja. So thank you for being here. I would also like to thank Ajit Thakur for organizing this meeting, Divesh Arora for taking all the pains to get the people together, Geetika I would like to thank, and Sanjit Pandey who coordinates our DNBA students. Also, I would like to thank Dr. Hilal Ahmed. I hope you are somewhere in the audience because you are anchoring the medical education at this institute. So thank you so much for everybody, and I'm very warmed and very honored to see the auditorium with so much of interest. So it gives me really great satisfaction of creating this kind of infrastructure where it can be utilized. So thank you very much, everybody. I'm especially thankful to Raja for having taken that. We have been together for the last few days, and we are going to be together for next few days. So I have one little demand, Raja. Please give access to some of us to your department. We have pain clinician here, and there are other pain clinicians, so that they can really sharpen their skills on what is happening at most advanced university. So give them little access to our boys and girls, and give them exposure whenever you have a chance. Thank you.